I'm gonna hit record. Hey everybody. Welcome. I don't really know what to call this other than four awesome prenatal and pediatric chiropractors who wanted to get together and have a conversation. We actually were supposed to be on a panel a couple of weeks ago, and things fell through on my part, and we said, why don't we just get together and have fun and do this together? So we just decided to get on and do it, and we figured we'd record it and share with whoever might be interested. So I've got I'm Ian Shtulman. Who's with me?
I'm Jen Santos.
I'm Steph Libs.
And I'm Bryant Harris.
So we got East Coast and West Coast representing here.
Yeah.
I wanted to, we each kind of prepared a few questions to ask the others, and hopefully we'll have a fun, enlightening conversation for that's interesting for people beyond just the four of us. I don't know. I actually wanted to start off with something just kind of fun. What is the most embarrassing thing that's happened to you as a chiropractor? Steph, you're laughing the hardest, so why don't you go?
I got plenty. Okay, I'll give you two. Okay. So when I'm doing a first visit with someone, sometimes I just get in the role of asking questions and doing all these things. And I had this woman come in first visit, and she was coming in for, wellness and some fertility stuff. And she was we were talking, and we were just flowing and really connected. And she was like, yeah, and sometimes intercourse is a little bit painful. And I was like, oh yeah, what position? It just came out of my mouth. Why did I need to know what position was painful? I didn't need to know that. It was not clinically relevant at all. And I just rolled with it, and she told me the answer, and I was like, great. And I was like, why did I say that? No relevance at all. So that was pretty embarrassing. Yeah. Were you gonna say something, Ian?
I was gonna ask, how did she respond? Did she was she startled by it, or she thought it was a totally normal question?
She just told me the answer. She had no qualms about it at all. But in my mind, I was like, why did I just say that? Why? It made no sense, but it just came out of my mouth. I have no idea why. So that was one that I always hold on to. I was just not in my mind. I was just flowing. And then I always like to tell the story of no offense to the guys, but there's so much that you'll never experience as a woman in practice. And one of those things is completely leaking through my top with breast milk, adjusting someone, right? So trying to figure out how to manage your flow literally in practice and your flow of your breasts, right? Putting those two things together is really quite tricky. So literally squeezing breast milk onto patients, that was fun.
I mean, I've had situations where my AC went out and I was dripping sweat onto patients while I'm checking, but I've never leaked breast milk or any other bodily fluids onto a patient.
Thank God.
Pretty frowned upon.
All right, you guys go.
I had one where I had a woman come in, and she was, I don't know, 38 weeks or something. And she was just pissed. She was just so mad that day. And I was like, what's going on? She's like, nothing. And I was like, okay, all right. And I just couldn't let it go. And I was like, really, tell me what's going on. She's like, I'm just very sexually frustrated. My husband will not have sex with me. And I was like, oh, what happened? And she's like, well, as soon as we found out it was a girl, he just hasn't wanted to have sex. And I was like, okay. And so we're I'm really sorry to hear that. I adjust her. Her husband comes in an hour later, and I'm like, hey, how's it going? And he's like, did she tell you? And I was like, tell me what? And he was like, that she's really mad at me. And I was like, yeah, well, I mean, she said something, but I don't really know what that's about. So what's up? And he was like, nothing. It's just, she just gets mad sometimes. And I was like, yeah, I mean, okay. And I was like, well, what's going on? And he's like, okay, can we just talk? And I was like, sure, what's up? And he was like, ever since we found out she was having a girl and I've seen the baby on the ultrasound, like, I just have this like fear that either I'm going to get the baby pregnant or that we'll be having sex and we'll be having sex and the baby will just grab my penis and I'll be stuck. And I looked at him and I was just like, oh, dude, you are probably not big enough for that. And it just fucking came out. And I was like, and then he was like, well, tell me. And I was like, well, you have the cervix and like the cervix is there. And so you're not pushing. And pretty soon I realized like I am like in the middle of my office, just like explaining that a baby is not going to grab the penis because you have a cervix and there's amniotic fluid and like, and I look around and there's just these, my husband is adjusting these like two older women that are just like looking at me and they're just like totally fascinated. And I was like, so that's, you know, just anatomy. And they start like clapping. And, and I was just like, and then I look over and there are two other dads and they're just like, huh, okay. And I was, and the guy was like, okay. And so then he came in, or his wife came in like, I don't know, 2 days later and just had like the smile and just gave me a big hug. And I was like, okay, there we go. And she was like, thank you so much. And I was like, all right. So there we go. That was probably the most embarrassing thing.
You relieved a lot of frustration for them.
Yeah.
Was he scared that the baby was going to grab his penis, or was he scared that the baby was going to be able to grab completely and close fingertip to thumb?
I
don't know.
Yeah, right. Yeah.
Oh,
This is terrible.
I was very scared it was gonna get stuck.
That's you know where we are.
Yeah, that's where we are.
Bryant, what about you?
So mine doesn't have to do with sex, like both of these lovely ladies on the West Coast. So me and Starbucks coffee, especially Starbucks lattes, do not get along. So one morning I opted to get a Starbucks latte and I started burping. And then one of my practice members was like, are you okay? I was like, yeah, I'm just burping. It's fine. And we go about, like, I start checking her and doing whatever. And it's becoming a little bit more frequent. She's like, are you okay? I'm like, yeah. And then I was like, no, I'll be right back. Ran to the bathroom. I vomited, came back. Then all of a sudden, keep on checking her. And then I start farting. And I was just like, are you okay? I'm like, yeah. And then I left. I was like, I'll be right back. Went to the bathroom, did what I did, came back. She's like, you okay? I'm like, yeah, I'm good. And then all of a sudden I start burping again. She's like, do you need me to leave? I'm like, no, we're good. I was like, yes. And I started vomiting in the trash can. And like, I pushed her out the way, trying to run to the bathroom. And then she saw another person coming up that had a baby. She's like, don't go up there. Don't go up there. He's not okay. He's not okay. Just reschedule. He's not okay.
That's amazing.
So good.
No Starbucks for Bryant.
No, Starbucks is trash.
Oh my goodness.
All right, Ian, what about you?
I mean, I posted this story once on the ICPA member community page, but I was kind of crouched down in like a catcher's position, with a baby sitting on the mom's lap. And, I'm checking the baby's legs and I'm doing this and I'm moving around a lot. And a fart snuck out. And I didn't quite know what to do, but my first instinct was to blame it on the baby. So I said, wow, that was a big fart from you. And the mom just looked at me and goes, she's sitting on my lap. I know that wasn't her. And so, yeah, that was one of those moments in
Can't blame it on the
practice
baby.
that I felt like embarrassed that I would blame it on a baby in the first place, but the fact that mom absolutely saw through me was just awful.
Did you
Oh,
learn
it's so good.
anything in that moment, Ian? Did you learn anything in that moment?
I learned to start working on my Kegels and hold it in better. Yeah.
Okay.
Oh my gosh, these are so good. Well, I love that Jen and I have stories about Rex, and the two of you have stories about farts. It's like so in line.
Yeah, it's perfect. Oh,
Well, I actually really love that question because I think it's important to highlight that, like, I always think about like, oh, like we're experts, we've reached this like expert status, but like we still are like figuring stuff out and making it work, and like have these like ridiculous scenarios in our offices. So
Or at home visits. I mean, sticking somebody, my thumb in someone's butthole
yeah,
is
the dirty Santa story is pretty
it's pretty embarrassing.
yeah. For anybody who doesn't know that story, go back and watch Jen's talk at the ICPA gathering.
yeah.
Because without that context, that just got super weird.
Yeah.
Hey,
Sticking your finger in someone's butthole. Yeah, for that Logan contact.
I
Yeah.
am an expert in my field.
Well, Dirty Santos, what question? Give me a question that that you brought.
Oh, well, I think we're aligned to Bryant. Um, I have a question about frequency. So at the what was it, the Mile High panel, it was brought up. So I guess my question is volume. So that seems to be an area of contention with a lot of chiropractors, and something that I'm interested in, because I think you can have quantity and quality, and they don't necessarily need to be sacrificing one for the other. And my favorite response when a chiropractor was asked, how many people do you see in a day, was by Carol Phillips. She was at a seminar one time, and they were asking a panel, and they said, like she was on a panel with a bunch of male chiropractors, and they said, oh, I see 200 people a day. Oh, I see 150 a day. And she's going down the panel, and they get to her, and they say, how many people do you see in a day? And she said, one at a time. And I think that was a really big, like, I love that, right? Because it was like, it doesn't really matter, like your like how often you see people, like how many people you see in a day, but whether you are intentional with every single person that you see. And I think that was like a really big aha moment for me, because I do have a higher volume practice. And so that was kind of like a moment where it really became clear that you can see a high volume and be really intentional with what you're doing. So I guess that was my question, is how many people do you guys see in a day?
Who wants to
Who
go?
wants to start?
I mean, I'll go. I made it a priority when I was early in practice that I was going to spend the same amount of time with a patient, whether it was my first day and I only saw 2 people, or 10 years down the line and however many I was going to see. So I made it a priority that during my visits, people come in, they lay down, I ask them a question that I ask everybody, what's new and different, and kind of give them the space to talk about. If they want to talk about what they're feeling, fine. If they want to talk about their kid's graduation, fine. Like, I don't really care. I just wanted to create that kind of space for them to talk. And while they're talking, I'm checking them. Now, if they say something that I need to like pause and go and do, look at something else, I will. But I'm checking them, and while I'm checking them for subluxation, I'm doing my education. Hey, your leg is short. That tells us there's tension here. You know, oh, we have to adjust the sacrum. These are the nerves that exit and go to the uterus and your pelvic floor. And, you know, I'm kind of talking while I'm checking them. Make the adjustment, confirm that my objective indicators are clear, and then, you know, wish them well. Hey, we're going to see you Monday. Give them a little bit of education and then kind of go on their way. I never wanted to sit there and spend a lot of time. And part of that is also that I really focus on developing relationships with massage therapists and pelvic floor therapists and, you know, mental health counselors and all these people who can be referral sources both, you know, both ways. But this way, if they want to talk about soft tissue stuff, hey, go see this person and they'll work on you. And so, you know, every day is a little bit different as it is with any practice, but I think we have, and this is the first time I've ever spoken about numbers publicly. My associate and I together, we see a typical week is between 5 to 550. You know, obviously it's a lot easier to see four, you know, a family of four than it is to see four individual people. So it helps that most of our patients are coming in groups of families. But my focus from day one has always been about, I'm going to give this person the most precise adjustment that I can give them. If there are no objective indicators for subluxation, then we're done. And if there are objective indicators, then I'll continue adjusting until they're clear. And then that's it. I'll move on to the next person. So we set up in a way that we can be very present and very intentional, but still be able to see quite a few people. You know, so as far as by myself, you know, I can see somewhere, I don't know, between like 80 to 100, depending on, you know, how many new patients or whatever is going on. But honestly, like, you know, like you said, it's one at a time, and it's about who, you know, how intentional you're being with that one person. And, you know, making sure that you're not sacrificing specificity for quantity.
Right. Cool.
I mean, I can go next.
Go ahead.
So, yeah, I don't see that many people. I don't. I probably see as many as a week as Ian sees in a day. So I have not broken the 100-person threshold in practice in a week, which is fine by me. But I typically see roughly around 25 or 30 a day. I work 3 days a week, but I allocate possibly, I see 2 people every 10 minutes, but I'm very present with them, and I do what's necessary. And I have no qualms with having people wait, because I tell people if that was them that needed extra time, then they would want that extra time for themselves as well.
Totally.
So if they're in a rush or something else, I was like, okay, they can come back another time, or they can wait. But I try to be very diligent and on time. But yeah, I'm not high volume by any means.
Nice.
That is for some people. That is high volume.
Yeah.
Yeah, I mean, I was like, I guess it can be, but I mean,
Yeah.
but for me, like, is there space for growth? Yes. Do I have things that I could fix within the practice to make sure that I have better retention that could cause for me to have longevity? Could I increase the frequency in which I see people? Yes. But ultimately, as you were alluding to, Jen, before, it's like, okay, you know, people want to talk about frequency. People want to see like how many numbers. And it's like, I guess it always boils down to me. It's like, okay, when you're seeing that many people, you want to have that number. What is that really about? Is that about ego? So you can tell other chiropractors, I see X amount of people.
Right.
Is it about the fact that you, and I'm being very candid and honest, it's like, you got bills to pay, therefore you're going to increase the frequency so you can get more money out of this person. Or like whatever it is, it's like, okay, if your objective outcomes are actually changing and you're doing a sufficient job, then I was like, my frequency in which I see people probably isn't as much as what y'all see people. And we may have talked about that in the past. Like my frequency is very conservative compared to a lot of people. So I don't see, so my numbers reflect my conservative care that I give people.
Steph, why don't you answer, and then we can have like a, because there's a lot that I think we can go back and forth and discuss, and I would love to hear from you.
Yeah, so sorry, there's a helicopter hovering, so I'm like muting myself. I don't know. So yeah, so I have 4 associates myself. So there's 5 of us docs. 2 associates are part-time, so they kind of take the place of 1. And as a practice, we see anywhere from like 5 to 550 a week. Some of our days are half days, so we only have 2 full days and then 3 half days of practice. So we're kind of in a transition right now, because in hiring my newest doc, we're going to expand our hours, we're going to expand our days, and so that'll give us the capacity to see more people. We do work a little bit slower, so we see, you know, our adjustments are anywhere from like 2 minutes to 15 minutes, just depends who it is. You know, if it's like a toddler who's coming in just for like their typical routine wellness thing, you know, 2 minutes. If it's a mom really struggling and it's a baby and, you know, there's a lot they're going through, then like I will slow down and take more time with them. And that's the beauty, like that. I like doing it that way, because now that I have a team of docs, there's typically anywhere from 2 to 4 docs on at a time. And it's really nice because it gives us the flexibility. And I think Jen's office is the same. Like, patients arrive and they just see the next doc available, and that's how we've made it run. Also really nice to be a mom, to be able to step out or to travel for seminars and stuff. So that works really well, because if I do need to take a little more time with someone, then the rest of the team just picks up the time, and it works out really well with our flow. Before I had my first daughter, I was seeing about 250 to 280 a week by myself, and I was killing myself. I did not like it. I also do a lot of side posture in my office, so it's a pretty like heavy physical adjustment, right? So, and I had a bad first birth, you know, so that was a really good learning lesson for me of like, I've got a cap of what I'm comfortable with, and I shouldn't go over that. So, you know, we're very like flowy in how we run it, but everyone here sees anyone from, you know, all of our docs see anywhere from like 30 to 60 people a day, just depending on the day and the flow.
I think there's something that's really important when we hear about numbers, because usually numbers are presented in the context of, look at me, look how wonderful I am, look at this massive practice that I built. You know, that doesn't mean anything. I wouldn't brag about numbers, you know, in general, but I certainly wouldn't brag about numbers unless I was confident that I was providing the best possible care, you know, for this person. The other thing that I think is really important is, you know, the numbers are going to be a reflection of multiple things, not the quality of care or the quality of the doctor. There's going to be a level of like, what fits your analytical style, right? Your mindset. If you're somebody who has a super analytical mind and you're doing some really complex, like, you know, X-ray line analysis, you know, you might not have the capacity to see as many people. If you're somebody who's a little bit more, you know, you're a little bit more direct and decisive, then you can probably see more. But it also depends on, you know, what fits you as your style. I know that there are chiropractors who just could not move as fast as me, and I also know that I don't have the patience to do the in-depth work that, like, I know Bryant does with some, you know, some kids. That's not how my mind works. I mean, you know, one of the reasons why, you know, I love chiropractic is because I focus on the subluxation correction, but I also love chiropractic for everything else that's available. I just don't have the mind, the patience, the you know, ability to like just sit with somebody and do all of the other stuff that's available. And so I don't think, like, when you say 5 or 550, you know, it doesn't mean anything other than this is what fits my personality. It's what fits my technique style. It's what fits the number of hours I make myself available. You know,
yeah. Well, and I
so
think that's a big deal too, because like, you know, like I said before I had my first kid, I was like, I was just pushing myself way too much, and it was too much for my body physically in a week. I was like, I'm not comfortable with those numbers anymore. And you know, the way we have it now, it's like, okay, we have time in the day that someone can go have a snack. You know, there's a minute for someone to have a snack, you know, which I think is really important. So, but I also think, Bryant, you mentioned like being conservative with your care, which I'm pretty conservative with my care too. There are very, very, very few people that I start at 3 times a week. Almost nobody starts at 3 times a week in my office, because I find it's a little bit unattainable for those families to start 3 times, and then they feel like they're failing if they don't make it here 3 times, and then they're not as compliant, and then they don't stick with their care. So I find, depending on what's going on, somewhere between 1 and 2 times a week is typically where I start people, depending on what's going on. And that just feels better for me. And I think I get better results and better retention with that. So that feels really good to me in my office too. But also, like, the financial piece is a really important thing to talk about, because you can have a super high volume practice, low fee or whatever, and like that works out really well. Or you can have a lower volume, higher fee, and like there are so many chiropractors I know who see a way lower volume and make way more money than I do. And that's fine, you know. So it is interesting just coming up with all the numbers. And I'm not super analytical. I actually stopped looking at my numbers for a really long time. It's funny you ask, I only just started looking the last like 2 weeks, because I started looking at where we can increase our hours. And then I just so happened to stumble upon our numbers of like, oh, cool.
Yeah.
Yeah.
I do the same as far as frequency. You know, I usually tell people that if I had my way, we would see everybody every single day until they were holding their adjustments. But that's just not realistic in today's world. And so I usually tell people that, you know, we'll start twice a week. And as soon as you're showing objectively that you're holding, we'll reduce the frequency, because I don't want to see people, you know, 3 times a week for the rest of their life. That doesn't seem, I don't want to get checked that often, let alone, you know, try to convince people that that's necessary. So for me, you know, it's always been about like what makes sense, that is also going to be realistic for people to be able to follow through, and not like beat themselves up and create more stress trying to get in. Because, you know, we've all had patients where they feel more stressed out trying to make their appointments than the effect chiropractic is having on their you know, adaptability.
So I'm curious, I'd like Jen to talk about this, because for me, what I find is like my membership style and like my payment options make it super easy for people to sign up for care. So like, I don't do any selling, I don't do big plans, I don't do anything like that. It's just, here's what we recommend you start with, this frequency of care, and go to the front, and you can pick your option. And you can do membership, or you can do bulk visits. You can come as a family or an individual. So Jen, I know that you do membership style, so maybe you can talk about like how that makes it easy to there's no sell, right?
No.
Yeah.
Yeah, I mean, so we have a membership option or a per visit option. I would say probably 95% of the people in our office are on a membership. We also have 3 locations, which also makes it a lot easier for people to get into a location, because our locations are all open 6 days a week. So our availability is a lot higher, I think. I typically do start people off at about 3 times a week for about 2 weeks. And I'll tell them, like, if you can't get in, that's okay. But it goes into like the frequency thing for me came from a little girl who I was checking and would not hold an adjustment. And I checked her, you know, and adjusted her, and then she would nurse for 45 minutes or an hour, and then she wouldn't be able to nurse the rest of the day. And then her mom would bring her back. And one, like, I don't want to be an expensive Advil to anyone. And that's not my objective. But when we see neurological indicators like not being able to breastfeed, being able to breastfeed, and then not being able to breastfeed, that's an indication that there's some sort of dysfunction. For this little girl, it ended up that she had microencephaly and lysencephaly, which instead of having gyri of her brain was completely smooth. And so that kind of, for about 8 weeks, I saw her every single day. And that, to me, that I was, 6 to 8 months into practice, I had emailed Michael Hall and Drew Rubin, and I was like, what is going on? Like, and really nobody was able to like give me any more answers than, well, maybe you're just not adjusting it all the way. And I'm like, okay. Okay. And like, I get it. I'm, 6 to 8 months into practice, and that was a big, like, okay, what am I missing? And so finally, like, my husband started seeing her also. And so we're both kind of like tag teaming. And then we finally got the diagnosis, and it was like, well, yeah, I mean, there are limitations of matter. And so respecting, going back to our principles and realizing that, there are also, I mean, when we're dealing with kids, like, I am never going to adjust a kid that doesn't want to be adjusted. To me, like, yeah, I mean, to me, it goes into like what we're doing is so neurological in nature that like we want to come into their system when it is accepting. And so what I tell parents is, I want you to bring your kid in 3 times a day, or not 3 times a day, 3 times a week, at first, just so they get used to the office. We do have drop tables that are quite loud. They sound sort of like Darth Vader and a construction zone. And I want kids to get used to that sound. They're the Zenith tables, if you're thinking of it. Like, what the hell? They're set up to an
like the hydraulic ones.
Yeah.
Okay.
Yeah.
Okay, got it.
So part of it is like, I want kids to come in and just get used to the sound. What we find is kids who are born into the practice, they don't have a problem with the sound. Like, it's sort of like comforting to them. My kids and my chiropractors, my associates, they've all been able to, like, our babies are able to like sleep through it. And we find that a lot in babies who were in utero where mom was getting adjusted, is they're able to do that. So to me, like Bryant said, is it like a pocketbook issue or whatever? I've always had a problem with that, because I mean, going through clinic, like, in school, you're trying to figure out like, oh, well, I really need to graduate, so why don't you come in 4 times a week? Why don't you come in 3 times a week? And you're making recommendations because you want to get the hell out of there and get done, and so for me, it was always like, I don't want that to ever be a question for somebody. And so the membership style practice really allowed that to remove that financial consideration. So if I tell you I want to see you 3 times a week, it's because that's what I think your nervous system is going to do best with. Whereas if I start you at twice a week or even once a week, that's because that's what I think is going to be better for you. But we've kind of removed that financial consideration, which I quite enjoy, because it's coming from a true place of authenticity, as opposed to like, trying to figure that out. And yeah.
I think what's so cool about this is it's like, it doesn't matter what you choose to do, just have it be authentic to you.
Yeah,
exactly.
I see so many people who try to replicate like practices of others, and if it's not authentic for you, 1, you're not going to enjoy it. 2, you're going to struggle to succeed and keep it up. And 3, there's so many opportunities within chiropractic to really customize it to what fits you. Like, that's the whole point of like owning a business. And one of the amazing things about like our profession is that you can really do it any way that you want. And as long as it's authentic and not coming from a place of ego or greed, I support your choices.
Mm-hmm. Yeah. And I think that's what's so cool is like, you can make it any way you want, and that's something I remember learning in school, is I would shadow a different office every week when I was in my last couple quarters of school. And I saw so much variety and so much like really cool stuff that you can make it whatever you want. And so like I'm kind of like a little bit of a hybrid with Jen and maybe some other styles, because I have a membership style, but it's also based on frequency and, you know, and then some other options of like packages and stuff. So like that just, and I didn't do packages for a long time. Then people asked for it and I was like, sure, let's offer it. And now a bunch of people love it. So it's so funny. It's like, I like having those options when I go places too. And so that's what feels good in my own practice.
Awesome.
Yeah.
Bryant, I want to hear from you. What's one of your questions?
To be honest, I didn't come with any questions. I was going to be an observer and I was going to answer, and I have none. And I was having some Wi-Fi difficulties, so I had to switch networks, and because people were frozen, so I have none. So I'm going to pass it to Steph. Steph, what question do you have?
God, okay, let me think here. No, I'm kidding. Well, I feel like it would be good to talk about some of the stuff we talked about on the panel, which of course, Ian, you weren't there. Rude. I'm kidding. Which for people who are watching this, if you were at Mile High, Ian couldn't make it because he had to get home to his family for baseball, and he's the coach. So like, family man, that comes first. They moved our panel. We were supposed to be Friday. We moved to Saturday. It's fine. But I think there were some really good questions and discussions that came up on the panel. So I think it might be nice to revisit some of that. Like there was a lot of discussion around tongue tie and breastfeeding and that kind of stuff. So I don't know, maybe we can go that direction.
Go ahead. What do you want to go into?
I don't know. I'm just starting the topic. Well, there was a lot of discussion on like a lot of discussion on like why we have tongue ties in the first place, and frequency of care around ties that came up. So yeah, do we want to talk about?
I would love to hear your perspective, Miss IBCLC, right? Like, you've got both the breastfeeding perspective and the chiropractic perspective, and
yeah,
I mean, personally, I would love to hear what you have to say about it. Okay,
well, why don't I rant a little bit and then you guys can tell me what your thoughts are. So there's like so much, I don't know if in your guys' world, I'm sure it's the same, so much discussion around like airway and palate and oral facial development and stuff like that. And I think that there is a huge connection with position in utero, birth, cranial structure, and ties. And then also the continuum of how we're raising babies. So like I have this whole thought on swaddling babies forces them to sleep on their back. And we have this whole back to sleep campaign. Babies are more likely to sleep with their mouth open. So is it really a tie causing them this open mouth breathing, or are we putting babies on their back and making them sleep on their back, which is creating a whole like altered dysfunction, airway sort of pattern. And I remember learning in Michael Hall's class about the importance of belly sleeping and how that changes the way we breathe and, the expansion of the rib cage and stuff like that. So that's kind of like one little piece of it. I also think that there's not a standard of care around tongue tie assessment. So like we all have that tissue, and it's a matter of, is it functional or not? So I really like the Hazel-Baker assessment tool. I like using that for ties. It doesn't take into account the latch-on mom, but it takes into account appearance and function of the frenulum, of just the tongue, not any other structures. So yeah, those are kind of my initial thoughts around all of that. And we talked about some of that on the panel at Mile High. So what do you guys think?
I mean, as somebody who wasn't at the panel, I couldn't agree more as far as the positioning issue. Babies go from this, especially in a subluxated pelvis, in a scrunched up, restricted position. Mm-hmm. Then they're born and immediately scrunched up into a swaddle as a way of suppressing their refluxes and forcing them on their back. Then they go into a car seat, once again, restricted, scrunched up, not able to engage their neck muscles and propped up in a way that they end up with, underdeveloped muscle tone because they're already propped up looking up. And then they go into like, you know, from device to device, from swaddle to carrier, and they're constantly here. And I find that so many kids who come in with a tie also come in, you put them down on the table and they're like already scrunched up. They don't feel relaxed. You know, you try to do a leg check on a baby like that, and you're like fighting them to try to get their legs to straighten out. So I think it's you know, a whole body tension issue that just happens to be assessed orally. You know, we tend to, I mean, I've been in this long enough that there's a cycle to blaming everything on something.
Yeah.
You know, especially prenatally, when I first started off, everybody had a big baby, and then everybody had a small pelvis, and then everybody has low amniotic fluid. And, you know, there's always something that seems to be the thing. And I've noticed that, you know, we're kind of at that peak right now with ties. I mean, I have babies who are coming in who have had a tie release before they left the hospital.
Right.
You know, and to me, it's the question isn't, is there a tie? The question is like, why is there a tie that's restricting, you know, performance? Like, why is that tissue so much tighter on this child than it is on this child? Right. And that's something that's just not being addressed conventionally.
That's a really good point, because I see so many babies where I'm like, oh my God, this baby's anatomy looks exactly like that baby's, but this one's totally functional and that one's not. What the heck is the difference?
I mean, that's the question that Dee started chiropractic, right? Why is one person get sick and one person get, you know, stay well? You know, the question isn't about anatomy. The question is about what's that anatomy able to do and what's interfering with it, right? Like I've had moms, you know, 6'3", super wide hips, struggle to get a 5-pound baby out. And I've had moms who are 4'11", 100 pounds soaking wet, push out 9-pound babies without any issue. It's not about the size or the body. It's about the performance. It's about, you know, what's allowing the body to do what the body wants to do, or what's interfering with that. And we're not getting to the root of the question here. We're just addressing one of the symptoms and leaving kids to be in that restricted, tight space, you know, and it manifests other ways as they get older.
For sure.
And then some of the things that like, I take a little bit like, I have a interesting perspective, maybe not so much interesting, but I don't want to say different either. But when I talk to parents when they come in with ties, and I tell parents like, okay, children learn how to suck in utero. So yes, if they have a malpresentation in utero, that can affect the cranial structures, and the tongue isn't resting on the roof of the mouth, therefore it's not going to put enough pressure on the palate, therefore it's going to have an elevated palate. It's going to do all these other things, and it's also going to continue to put them in a sympathetic state. Because, you know, if you put your tongue on the roof of the mouth, it actually creates a parasympathetic response. And that's also going to allow you to feed better. So ultimately, when I tell parents like, okay, they're like, oh, my child's always waking up. It doesn't feed well. It has hiccups. I was like, well, look at it this way. If your child's laying on their back, yes, you're going to have your moral response, but if the tongue is not actually elevated towards the roof of the mouth, that child is actually going to be choking on their tongue. Like they can't breathe. They're going to have obstructive sleep apnea, essentially, right? So that's why this child is always waking up. They're like, this child's never sleeping because of that resting tongue posture. So ultimately, that's why when Michael Hall, anybody says, like laying on the belly is better because you get more oxygenation. And then I tell parents the same thing, like in the NICU, babies are all on their belly. Why? Because they can oxygenate better. And when they said, oh, my baby sleeps better if they're contacting me always, they're laying on the belly on me. I was like, no, go figure, really. Because of the structures that are actually going to be involved with that, it's going to be preventing them from doing what they need to do functionally in terms of those things. And then if you're constantly in a sympathetic tone, you're not going to be worried about feeding or digesting. So therefore, you're going to have reflux because you're not even thinking about any of those things. So from a neurological perspective, that child is not prepared or not concerned about that. They're just concerned about getting out of this stressful state, right? And then when parents, as to what Ian says, when they're coming out, they're like, oh, Like if they say my previous child had a tie, so I know this one's going to have a tie, so I'm going to be prepared. So I'm going to add this surgery or this insult to their neurology, which is another trauma, which is going to put them further into this whole sympathetic cascade. They're not going to want to feed after that either.
Right.
So it makes it very frustrating because like these parents think that they're making the best decision with the information that they know, either from previous experiences or based off of, lovely Facebook groups, right? But it just leads us, we just become into a sticky situation where if no one's able to adequately assess, and we said this during the panel at my high, and someone came up to me, says like, I didn't know chiropractors couldn't diagnose tongue ties. I was like, no, that is not within our scope. We can't say that they have a tongue tie. That's not what we do. Actually only dentists and ENTs can actually diagnose tongue ties. Like we can't, lactation consultants can't. So we're looking at what we can find, where the subluxations actually lie, whether it's in their cranium, whether it's in the upper cervical spine, what's preventing the body from functioning optimally, and do what we do and try to prepare them so that baby can function better. But it gets to that point where they're talking about like optimal timing release and everything else like that. And then people say like, you need to go see a body worker. Hate that term. But ultimately it's like, okay, you want to get them out of that sympathetic dominance. And when people say like their body's stressed or their body has a lot of tension, I ask them, what does that look like? Is it dural tension or is it just they have tight muscles?
Right.
They're like, well, what's the difference? I was like, well, if you don't tell me it's like my baby needs to come see a chiropractor because they're tight. I don't want to hear that. I tell my providers, like, don't send someone to me and tell them that they're tight and that's why you're sending to me. Because like, you're going to stretch my baby out, right? I'm like,
oh my God. Yeah.
No, I'm not stretching the baby. That's not what I'm doing.
Right.
So
Imagine
it's like, okay.
Armstrong, like pulling a baby and just
like a little device.
But it's like this, if they have increased sympathetic tone, there's going to cause those flexors to get really tight because they're going into protective mechanisms. Then if they have a oral restriction that's tethering, that's going to affect their dural attachments. Therefore, when their babies are always arching backwards, I tell them, arching backwards is taking tension off that spinal cord and off that dura, because going into flexion is actually causing more discomfort and pain because it's pulling on that tethering.
Yeah.
So it's like the fact that there are many individuals who don't understand how that neurology is going to be influencing this and what we as chiropractors actually can do to influence those things to allow for better function so we can avoid having potentially a frenectomy performed.
Yeah.
And I think that's the biggest thing, because even within that panel, the people in the audience was like, well, how do I learn more? Where did you learn this stuff from? Like all these other things. And it's sad that we get thrown in as a chiropractor and chiropractors like, yes, this is something that we can work with, but without having a full understanding of what it is that we do and how we're influencing it, it creates a lot of chaos, and it creates a lot of misinformation being spread about ties and other things, because end rant. I'm done.
It's a great rant.
I think looking at the difference between a posterior tongue tie and an anterior tongue tie is also really important, because we have enzymes that are meant to break down the like webbing in between our fingers and in between our toes and underneath our tongue. And understanding that if that doesn't happen, that, anterior tongue ties, I think, are an issue that I'm not really convinced that we're seeing at a higher rate than we were a long time ago. Right. I mean, they're like looking at like old midwifery textbooks and stuff. I mean, there are many anecdotal stories of midwives leaving their pinkies long, so they would like just clip the anterior tongue tie with their pinky. A posterior tongue tie, I think, is more of a functional issue, and that's kind of what you're talking about with like being stuck in flexion. Babies are born, in utero, they're in a flexed state. When we're flexed, being in that flexed position, we're going to have that when babies are then born and put into a car seat and put into that flex, we're also going to end up with like ligamentous creep or fascial creep. I was just talking to somebody that told me it's called, instead of Wolf's Law or ligamentous creep, it's like Davison. I haven't looked it up, so I don't know, but it's the theory that like the fascia will actually shorten when things are constricted. And that makes sense. Everything else in the body does that. We see when you put your arm and you walk around like this for 2 years and then try to straighten it, your ligaments and your muscles have crept. They've accommodated to that. When there's abnormal stress on a bone, Wolf's Law says it's going to grow more dense and thick in that area. And so when babies are born, I'm not even necessarily the one thing I think you miss, Steph, is birth trauma too.
Right.
Because when babies come out via C-section or Rinken maneuver, they're being pulled out, their hyoid is being compressed and shoved. And then that's going to completely create tension under the muscles, of the muscles under the tongue that are controlling and creating the posterior tongue tie. So a lot of that's like, I mean, at Mile High, I kind of plugged it a little bit, but like, that's where I really think dynamic body balancing has completely changed the way that I approach ties in my practice, because we're able to actually like release those, calm those muscles down and get things to be more functional before any release is even happening. So
yeah, I think there's a whole piece too with like the cultural norms of parenting and like newborn phase of, I see so many families that come in and they're like, struggling with feeding and latching, and everyone says it's a tie, but it's like they're trying to sleep train, they're swaddled, they're in containers all day, and birth trauma, like they're trying to feed on a schedule, which I think is one of the most detrimental things you can do. And then so it's like we're living in this world that is trying to completely disconnect us from motherhood and birth and breastfeeding, that it completely takes us out of our inner knowing of like how to connect with the baby.
Right.
And for me, I see a lot of that of like, okay, let's talk about like holding your baby more, which I know is demanding, but that's kind of what having a baby is.
Right.
Kind of what it is, right? Hold your baby more, feed on demand, sleep together if you feel like it, you can safely do so. Like trying to conform to all the, like, do you have a good baby? Do you have a good baby?
Yeah.
Like, what is that? So
Right.
I think that's a big piece of it too. It's like our society is just not meant for truly supporting families.
Right.
We've
But
lost
at the same time, it's
Go ahead.
oh no, but like I know this is something that you talk about often, Steph, at least on your social media platforms. It's like, okay, like a lot of people don't understand the whole premise behind co-regulation as well. In terms, like, I understand when parents come in, they're stressed out about their baby not feeding. They're stressed out about, like their baby not sleeping. They're stressed about all these things. And it's like a self-fulfilling prophecy for them that they don't understand that this child is actually regulating off of them. So it's just going to create this whole cyclical effect because they're trying to do all these things when for this child, it is developmentally appropriate where they're at to be like this. And as you said, cultural standards or cultural norms have said like, oh, you have a good baby. They're not very needy, but like, no, babies are supposed to be needy.
Yeah,
exactly.
I mean,
go ahead, Ian.
We've lost the generational knowledge that is traditionally passed down, through villages and communities. It used to be that kids would grow up and they would see people breastfeeding, they would see people giving birth, they would see people, going through this transition. And now most women, by the time they have a baby, they've never seen it. They've never been around it. The idea of breastfeeding seems like this mythical, aspirational thing rather than how you feed a baby. And, we've taken away all of that shared knowledge and put it in, separate families, generationally into their own homes and hide everything in these own little compartments. And what we've actually done is stripped people of the power and that innate connection to centuries worth of knowledge that's typically passed down. And what you see now is, I mean, even the advent of childbirth education is formulated because of our failure or that interruption in that generational knowledge. And I think it's just another example of us being disconnected from nature, right? Us thinking that we live outside of the animal kingdom, us thinking that, educated is better than innate. And that separation has created so many of the modern issues that we face. RFK Jr., made a big priority at Mile High when he was talking that our effort of stymieing infectious disease has led to the increase in chronic disease. And, it's this idea of like autoimmune disease, this idea of chronic disease that we face now is a direct reflection of us being afraid of nature and trying to interfere with it, trying to stop normal childhood infections from priming and developing the immune system and turning it into a situation where now we get to live with lifelong effects. We're dealing with babies who, because of our hiding birth and hiding breastfeeding, we've ultimately created a situation where now we need more intervention throughout pregnancy, throughout birth, throughout infancy, more dependency on medicine, more dependency on intervention. And it is just the complete antithetical approach to what we should be as human beings. And I think it's just, it's hard to think of like, how could we possibly get back? But this is all like, these are all the same issues that are boiling down to what we see every day.
I think there's something even more insidious about it when it comes to pregnancy and childbirth and breastfeeding with women, that women, in the 1950s, it was like you were supposed to be this stay-at-home wife who did this and this and this, and that was your role. And you listened to your husband and you were like, subservient or whatever. And now it's transitioned that we have not empowered women. We have given women this illusion that they're empowered, but they're not really empowered. It's been replaced by medicine. Hormonal birth control is probably one of the most fucked up things we have done to women in the history of womanhood. And then we've replaced
women's liberation. And
right, exactly. It's not liberating. I have so many women that come in and they're like, my doctor won't let me go past 41. I'm like, fucking who is in charge? Like, fire your doctor, get a new doctor, move on, and it's this idea that women are so removed from birth and the process. Like, I grew up in a family where I was born at home. My husband was born at home. And so that was just sort of our normal. And so when it came time for our son, it was like, it was never even a question as to whether or not we were going to go to the hospital, because in my mind, you go to the hospital when something is wrong. And I think that we've lost so much of that, and we've replaced women, this women liberation is such nonsense, because that's not really what's happened. We've just replaced it with, instead of our husbands being able to tell us, oh, you can buy this meatloaf or this meatloaf, yay, we're now just like, oh, you can have your induction at 41 weeks, or you can have a cesarean at 41 weeks. Which would you prefer? And it's like, they're both, we've just replaced it and just completely given over our, autonomy to the medical profession. And I think it's really wrong and sad. And it's also like, I could go on about that, but I think there's so much, like, we've replaced innate wisdom with technology so much that even with like ultrasounds, like, I have so many women come in and they're like, I didn't feel like I was pregnant until I saw it. I'm like, Google a picture of what a baby looks like in utero at 8 weeks. Like, it's like, you don't need an ultrasound to tell you. And we've replaced it so much with just, instead of trusting the innate wisdom of the body, we've replaced it with, oh, my doctor says this is what it is. And we're constantly on the hunt for pathology. And so we're constantly looking for that. And at the end of the day, the risk is really high because, you know, everybody wants a healthy baby at the end. So of course you're going to jump through these hoops to try to figure it out. But you look at other countries and the way that they monitor pregnancy, and it's so phenomenally different. And we have literally the worst birth rates in the world for industrialized countries. Like, it's just, it's sad and laughable at the same time. So there we go.
Yeah, but like one of the things I wanted to chime in about, like, and one of the things at least I noticed in DC, and then also like culturally, like in being Black and hearing some things as well, it's capitalism and affluence played a huge role in birth. And what I mean by that, as with this, as you said, with women liberation movement and all these other things, and all these women who chose to be, you know, working parents or working moms, they're like, okay, listen, I can afford to have a C-section. I can time when this is going to happen. I know when I can end work. I can do all these other things. And then I can, you know, and I had one person say, well, I want a C-section because I get 8 weeks off of work, not 6, right? So it's this capitalistic culture in terms of like, okay, there's that aspect. And then when it comes to breastfeeding, you know, for a long period of time, with the introduction of formula was expensive and is still expensive. But I know for, you know, for Black people, with being historically being wet nurses and having some negative stigma around, you know, breastfeeding, and then it got turned into, oh, I'm affluent because I can afford formula. Breastfeeding is for poor people. Why would I want to breastfeed when I can afford to buy formula?
Right.
So it's like, I feel like the capitalistic culture that is America and how we do things, that also perpetuated, you know, medicalizing all these things and trusting educated mind versus innate. And that's what also makes us different from other industrialized nations, is because like these companies aren't indoctrinating us and thinking like, you know, this is a measure of success, is being able to do all these things. It's no different than getting a SNU, no different than getting that expensive, like, you know, car seat or expensive stroller. That it's garbage. But you're like, I can afford that because I'm of this level, and this is a thing that I can show. This is a thing I can do. This is all these other things.
Yeah,
I think that didn't help the cause whatsoever. So
for sure, agree. There's so much history, especially with the formula industry, of like, you know, there have been formula CEOs publicly making statements about how they want unemployment to go down because that means more moms are going back to work so they can sell more formula. You know, instead of like giving moms proper maternity leave coverage and keeping them home with their babies. But you can't say that because that sounds like anti-feminist and you're wanting to keep women in the kitchen, you know, when really, like, from a biological perspective, we should be with our babies. We should have time off work for an appropriate amount of time, you know. Yeah.
Boy, there's between, you know, feminist and racial stuff, there's so much. I want to go on a woke tirade right now, and we can hold that off for another day. But yeah, like it's such an important conversation that, you know, we see the effects in our practice, right? And, you know, many people don't realize how, you know, these health outcomes are connected to economic factors. And it's just interesting that we went there. I just think it's yeah.
Well, it's interesting too when it comes to like managing a team also, right? Like Jen and I talked about like maternity leave coverage for our team, and as a business owner, that's hard. That's hard to manage that and to like pay people and have them out and all that sort of stuff. But it's also like what I love about my team is that like we've kind of, you know, built things in a way that's like easy for people to step in for each other and cover, and you know, hopefully make it easier to be a mom who also works.
Right.
You know, and it's hard to do that. And my first kid, I could not bring to the office. She only wanted to be with me. It was just not going to happen. My second was like the happiest baby. He would let anybody hold him. So he was just passed around the office for like months and months and months.
Yeah.
So, you know, and I know Jen has a lot of her team bring their babies to their practice. And you know, it's nice to have a profession also that, like, when I came back to work, I started at 2 half days and I slowly worked my way back up. And that was a much easier way to transition into being a working mom than just being thrown right back into work full time, you know?
Yeah, I think it's really dangerous, especially like in the chiropractic world. There's this like almost this like weird badge of honor of like, oh, I worked until I was crowning, and then I went home and had a baby, you know, and it's like, oh,
and I came back to work at 2 weeks.
Right. And
off.
it's like out of necessity. Like I went out at 38 weeks, 38 and a half weeks with my second, and went back 3 weeks later because I had to. Like we didn't have the option of not. And I think that that's really kind of fucked up. And like, so what we've done, we have 16 chiropractors in our office, and in the course of 1 year, this year, we will have 6 babies born. And what I will say is, in a lot of ways, like we are in California, which California actually has like pretty good, like you get 4 weeks off before, you get up to 16 weeks after. So it's a total of 20 weeks, which I think is really great. I've talked to other people in like Idaho and Indiana, and they don't have any maternity coverage. And I think that's insane. And so I think we're a little bit fortunate with that. We also have paternity or paid family leave, which gives our guys 8 weeks after. What I have discovered is it's actually more difficult to have the guys in our practice go out on paternity leave, because with the women, we can say, okay, here's your due date. You'll be, due date, which is a whole nother thing, but whatever. Here's your due date. You're going to go out 4 weeks before that. And then we can calculate it out and like, up to 16 weeks afterwards, and you can come back. With the guys, like right now, my little brother's wife is due on Monday. He works in my office. She's due on Monday. And it's like for the last 2 weeks and this week, and then the next 2 weeks, we're like, maybe he's working, maybe he's not. And as soon as she goes into labor, like obviously he's not going to be working, and then he's off for 8 weeks. And so it's actually been really difficult. We've had 2 guys have babies, and we'll have 4 women. And it's been really difficult with our guys because trying to figure out and navigate when they get that time off actually is more difficult. But as far as like from a business perspective, financially, it's been difficult having women go out, obviously. But we have them bring their babies to work because those who mind don't matter, and those who don't mind, don't matter. I don't know, whatever that is.
Don't mind.
Yeah, I don't know, whatever it is. But like, we have babies in the practice, and so like right now we have one that's been coming to work for the last 3 months, and everything. I mean, she gets held, and she's on the floor a lot, and it's really cool to see other parents see her on the floor, because it's like there's so much of this, like, I don't know, I call it like floor phobia, where like parents don't want to put their kids on the floor. That's so gross. And it's like, well, no, like we have everybody take their shoes off at the beginning, at the entrance of our office, and then she lays on like a little, like, she has a little thing, but she usually like runs away from it. But it's like having her do that, and then she's able to like have a ton of tummy time. She's on the floor a lot, and reaching those milestones, I think, is also a really cool thing for parents to see, that like this is what it looks like to have a baby that is allowed to move freely and not be in a snoo or wrapped up in some sort of device or container. And I think that's been really cool.
I think the future of chiropractic is in group practices, right, with multiple providers, because when my first was born, I didn't have an associate, and Sasha went into labor. It was like a Saturday night. Aaron ended up being born like Monday morning. So obviously I was closed Monday, and then I took Tuesday, which was a half day off. But I was back in the office Wednesday morning.
Yeah.
My wife actually went home from, because we had a home birth that transferred because of some fetal decel stuff. But she actually had to go home with my mother-in-law because I was in the office.
Yeah.
And I struggled as a solo practitioner, as a new dad of one. I really struggled emotionally, physically, spiritually, to find any sort of like balance / peace / happiness in my life, because I felt like I was letting everybody down at home, in the office, myself. And I wish I had set myself up by having an associate available that could have covered. Because it's a really tough thing when you're out on an island practicing, especially all of us, we have our own specializations. You can't just call up a coverage doc and say, hey, come take care of my patients. And it's the situation that you have going. I know as a business owner, it's really it's frustrating, because I've had people go out on maternity leave, and it's really tough. But just on a human level,
right,
giving your chiropractors the opportunity to transition into parents and still be able to return safely when they're ready is such a huge thing, not only for them, but how they in turn can take care of and encourage patients to do the same.
Yeah.
It's awesome.
Yeah, for sure. Yeah.
I actually, I know we didn't really discuss how long we were going to go, and I'm assuming if we just kept talking, we could probably go for a few more hours. But I did have a couple of questions. I actually wrote some questions down.
Oh, you did your homework. Okay.
Yeah.
Way to make us look bad. Yeah.
But like, I wanted to, one of the questions that I wanted to ask was, we've all been in practice. I'm in practice now 12 years or 13 years. How many?
I'm 10 and a half.
Jen, Bryant?
At 10.
I'm 15.
Okay. So like, during practice, like when we're taking care of people, you figure out like little secret techniques, right? So if you were talking to students or a new graduate and they asked technique wise, what's something that you've learned that allowed you to have better objective and subjective outcomes in your patients, right? Like something that's never taught, something that you've never heard, but you just figured out on your own. What would that be?
I mean, I would just say more listening.
Yeah.
Way more listening. I feel like I've learned to ask more questions and just listen. And that gives me way more information than most fans.
I don't need to get into a technique war, but I think the biggest thing that I realized is like, we're not moving bones, we're stimulating the nervous system. And I think that is a very big difference.
For me, I think the biggest thing is, it's like, trust your analysis. Like, if you find that they're clear, and then the patient's saying like, yo, doc, I think you missed something. I'm like, no, you good. Because I made the mistake of listening early on in practice, listening to one of my practice members, and they asked me to do something. And I was like, well, I don't think you need it. They're like, come on, doc. And I did it. And they couldn't get off the table after I did what they wanted me to do. And I was like, I knew we were done, but I listened to them instead of listening to me.
Yeah.
So it's like, trust your analysis, and when you know you're done, let it be done, and let the body do what it needs to do next. It doesn't matter if they're still in pain, if they still have that issue. I was like, listen, the whole point, and I was going to talk about this earlier with that frequency stuff, is like chiropractic is here to help you evolve, adapt, and grow. You need to give the body time to allow it to do that. You know, adjustments to be made at the right time, at the right place. You can't just be putting a force in willy-nilly. So, yeah.
I like that. I'm also going to just add to that with both of you is I have been trying to do less, right? Like less input usually creates a bigger neurological response, I find. And like something that was like big to me this year was like, okay, if their indicators aren't matching like your normal technique flow, something's up and they probably need more care. And I don't know why, like I've heard it, but I didn't really hear it until this year for some reason. And I was like, oh my God, my mind is blown. So that's been a big thing for me too.
I would add off of that because, you know, what I found is that if my indicators don't match up, I always like take a step back because like I'll check for like an AI sacrum using Webster, Logan, and Thompson, right? And if I'm not getting my listings to all match up with those techniques, I have to take a step back and say, all right, what am I missing, right? Am I checking the primary or am I checking a compensation? And so if I'm noticing that visit after visit, my objective indicators are not changing, right? If I'm still seeing the leg length discrepancy is the same, if I'm still seeing the same issues, if my patient is still having the same subjective complaints, I take a step back and I say, okay, maybe I've got the right listings, but I'm adjusting it in the wrong order. Or maybe instead of adjusting C1, I need to be adjusting occiput or C2. And so what I've really worked on with my technique is using objective analysis, but not as a technician, using my objective analysis to give me information that I can then use my doctor brain to figure out what's going to be the best form of input into this nervous system. Is it a drop table? Is it atlas first? Is it sacrum first? Is it more force, less force, the bone above or below? And how can I get more specific with my correction? And usually what I find is that if I change up what I'm doing, suddenly the next visit they come in and their leg length discrepancy is half of what it was. Or, wow, I've been toggling atlas the last 5 visits. Today I started with Logan and next visit you come in and we don't have to toggle atlas, right? Like, so like using all of these techniques, not as a, like, here's a flow chart, but here's things that give you information. And then you can look at your patient and figure out what makes the most sense for them and what's going to get you the best objective changes.
Yeah, that's really good. My struggle with that is remembering what I did with someone last time. But what's so funny, like that brings up a good point. It's like having a multi-doc office, like we have to find ways of creating consistency and communicating around what works for someone and what doesn't. So it's like we try and find these patterns and we try and have whichever doc sees them on the first visit sees them on the second. So we've at least got the first and second visit comparison with the same doc. And that's a tricky thing that I'm still trying to figure out. We're in the process of. What were you going to say, Bryant?
And one of the things that I do to that point, when people are presenting interesting or if my indicators aren't matching up, I have them go back weight bearing. I mean, that's how they live in life. They're living weight bearing underneath gravity. I was like, go walk around. Something's not working. Something's going on. Like if I clear out everything and their legs aren't balancing, I was like, what in the world? I was like, go for a walk. Something else is going on that's not presenting like this. And I do that more often than not with my pregnant practice members. I was like, listen, I'll adjust them. And I was like, go for a walk and I want you to lay back down. And if all of a sudden the pelvis goes back, I'm like, what the? And then I'm like, I do it again. I was like, go for a walk.
Take another lap.
Because I'm like, especially if, and I say this not trying to say that I'm treating symptoms or I'm affecting like their baby's position or anything else like that. But when I look at these practice members, I'm like, something's like, your body's not responding the manner that it should be. Something else is happening, and I'm not sure what. So I need you to walk around, because if I clear out these things and it's still something else is presenting afterwards, I'm doing something sequentially wrong. I'm not finding the primary that I thought was the primary. So it's not coming up, because essentially they're just reverting right back to the way it was. So I have them walk.
100%. And honestly, because of the urgency in breach situations, when I have moms come in and babies breach, I'll typically I'll adjust them, I'll have them stand up, walk around, lay back down, and I'll have them do that on repeat until there is nothing objectively that's present. You know, I don't, what was that?
I was like, I don't know if I learned that from when I visited your office or not, but I'm not going to give you that.
You know, for me, chiropractic is a process of, you know, the adjustment is not, like Jen said, you're not adjusting a bone to take pressure off of a nerve, right? Of course, there are those, you know, radiculopathies and situations. But to me, the adjustment is trying to find what's the combination to unlock that nervous system to open up the healing potential that has been stifled. And so sometimes that means trying out different levels of forces, or having them walk around and, you know, you got to tug on the lock a little bit to see if it opens, right? And challenging the body and seeing how they respond, you know, to being weight bearing, I think is a great way of checking to see if they're holding their adjustments for, you know, 1 minute, right? Let alone, you know, for a week or two.
Yeah.
One last question, and then we'll see if we would just want to end it after that. But, you know, I've always found that whenever I do any sort of speaking, humility and sharing my mistakes are the things that most attendees seem to resonate with the most. And this could be marketing, this could be practice management, this could be HR, this could be anything. Like, what's the biggest mistake that you feel you've made in your journey to where you are right now? Or, and if you want to think about it differently, right? Like, you know, what's something, if you could go back and do it differently, you would do?
That's such a good question. You guys want to start? One of you?
I'll, you know, not to answer.
I can start.
Go ahead.
So as everybody knows, that I am a seminar junkie, and I have gone through several iterations of my practice and utilizing different techniques. I would say have confidence in the technique that you choose, and stop making so many changes in your practice because you don't think that it's working. Like, I switched from being a full spine adjuster, then going to torque release because no one else was a torque release practitioner. And then I wasn't confident in torque release, even though I was advanced proficient. And then I missed manually adjusting, but then I was like, I got drawn into doing upper cervical and then all these other things. And I was like, I was a hot mess. I was doing everything and anything. And then I had no focus with what I was doing. And to some people, I still may not have no focus in what I'm doing, but I feel just have confidence in what you're doing and pick that thing and then keep going with it to have consistency and not create confusion in your practice and with your practice members.
Good. I feel like this is kind of a tough question for me because I feel like even the things that I failed at, I have learned from or tried to learn from. So I feel like it's like, there's not a whole lot that I would do differently, but there are certainly things that I've learned. And especially like bringing on a team and like how to be a boss. Like, I don't really particularly enjoy being a boss, and there's been lots of lessons learned from that. But one thing that I find really helped a lot was like asking my team for help when I need help and advice. Like, they've got a whole lot of knowledge also. Like, maybe they don't know the same things that I know, but they know different things, and they might have some really good ideas. So I really rely on my team for like helping with, you know, how can we make the office flow better? How can we make things better? So I try and ask a lot of that kind of stuff. It also makes them feel included, I think, in the process, and a little bit more like buy-in to the success of the practice. So I think there's that. But one thing I feel like I would do a little bit differently was, I don't know if I do this differently, but especially after I had my first baby, I went through a lot of postpartum depression and anxiety, and I became really like smug and like angry at our profession, and very like who are these people on stage talking about X, Y, and Z? Who do they think they are? They don't know anything. They've never had a birth. They've never had this. They've never done, like, I was so ego and like angry and bitter that it was hard for me to learn from people, because I was so like closed and like angry. And part of it, I'm sure, was like I was angry about my birth. But I just felt so irritated at so many other chiropractors, and like jealous of their success, and like, you know, just not loving. And it just didn't feel like I look back and I'm like, God, I was such an asshole. And I would go and sit in the audience and like have my arms crossed and be like, who do they think they are? And like not hear any of the wisdom that they had to share, you know? So I would change that.
What ultimately changed that for you? Because obviously you're on stage, and you know, you don't have that energy anymore. So
Yeah.
what did it for you? How'd you break out of that?
So I think it was just a slow evolution of like a change, and a lot of it I think came from like just starting to be confident in and being comfortable that I didn't know everything, and I don't have to know everything. And I feel very comfortable with that now, of like, there's a lot that I don't know, especially with birth. And like, I think my second birth probably did that for me, because I did have a home birth. It was much more straightforward. It was very healing for me. But I also, like, I went into that birth like, okay, this birth can't be like a redemption. I can't put that pressure on me and on the baby that I have to like redeem myself from the first birth. So I did a lot of like inner work, personal work to try and heal through that. It was a really great birth and a really great breastfeeding journey. And I feel like that birth was very humbling, because I felt so blessed to have such a good birth. I was like, there is so much unknown around birth and health and life. And like, us as chiropractors, we have this beautiful little role we can play in people's lives of like being a safe place for them. And sometimes that's all it needs to be. And that's fine, you know? And so I feel like I try to, you know, drop the anger. I don't know. It was just an evolution, I guess.
Awesome.
Yeah.
I think for me, that is also a really hard question, because I think my husband and I have been very intentional to look at what other chiropractors do and run the other way from the very beginning. And so like when we developed our membership model, like I thought we were the only people doing it. Like, we hadn't met anybody else doing it. We were constantly told it was illegal. We failed our business proposal because of, you know, our teacher told us it would never work. And we took that failed model and opened our practice. And I think there are so many things that like we've done. Like, my husband and I are not people that succeed with like farmers markets and like going to like a freaking booth and like spinal screening. Like, no, it's just like not my gag. Like, I hate it. it's just not what I'm going to do. And like, I personally would never go to a chiropractor that I found at a farmer's market. Like, nothing against it. It's just not what I would do. That's not how I would find my dentist. That's not how I would find my OB. That's not how I think of all of the things that we've done, like, I don't really regret anything that we've tried and like maybe didn't like succeed at or whatever. But I think probably the biggest one that sticks out for me is like our first associate that we had. I think is like a point of like, we grew a lot together, and like the first associate that we had, I think that there was still a lot of like, okay, well, we've struggled this first year and a half, so like, we want there to be a little bit of struggle or whatever. And it's like, once that associate left and our second associate came on, we came from a different place of like just fully abundant. And like, I don't need you to go through the same struggles that we went through opening our practice. And like, we have this awesome practice that we all get to benefit from. So like, let's just all make it awesome. And like, we really became very authentic with that, like in the way that we pay people and what we pay for. And we do like unlimited vacation, and there's so many things that we offer that I think really was a turning point for us after our first associate, realizing that like at the base of it, like we want to be good people and we want to like maintain like healthy relationships with people. And like, we've had other associates leave and they take our model with full blessing and permission and start another chiropractic club. And it's like, yeah, please do exactly what we're doing. Like, imitation is the best like form of flattery or whatever. And it's like, that's so flattering to see so many people starting practices that are so similar to ours. And I mean, we have somebody in our area that started their membership model practice and literally like copy and pasted our website. Like, and it's just like, okay, cool. I mean, spelling errors and all, luckily we found them. But it's like, I think a lot of times there's so much like insecurity with chiropractic and like, oh, well, I don't want you stealing people from me. And it's like, I don't care if we have 10 more membership model practices in our area. That's awesome. That just helps like fuel the flame. And like, yeah, I know that's a long answer, but I think probably like realizing that like, just because it was hard for us doesn't mean that it needs to be hard for our associates. And we want to give out of abundance and just like come from a place of like, we're so happy that they choose to spend their lives with us. Yeah.
That's awesome.
Yeah.
I would love to say that I had like a complicated, answer, but the reality is just office design. I mean, I've been in the same place that I opened with, and at the time I just assumed that at some point I would move to a different location, and my doctor's room, right, like our private office, is literally 5 feet wide by 10 feet deep, and I've got 2 doctors, myself and another associate in there, and we share space. And we have room for 3 chiropractic tables in our adjusting area instead of 4, because for some reason I thought it would be a good idea to have an odd number of tables, so like, if I would have thought some of that through, I would have had a little bit more room for growth. I mean, I didn't create like a storage closet. I didn't create like an IT closet. So like all of these things, are the things that you just don't think about when you're, opening or designing a practice. And so I wish I would have, I would fucking love to have a private bathroom, right? There is nothing worse than having to take a shit in the office and then opening the bathroom door to a new patient waiting to use the bathroom after you. It is awful. So
I would agree with that. I don't have a private bathroom.
So like, I wish, like, there's certain things like that like, it seemed like an extravagance when I first, did it, but you don't always get the opportunities to, move locations, and I wish I would have like, Yeah. 5
What'd you
times.
say,
I've done it 5 times.
Brian? Right, right.
The
Well,
office,
that's
the
actually a
office
good. Go ahead.
I was gonna say the office I'm in now, we've moved a bunch of times, but we're in like downtown Delray area. My other office, we're out like in the middle of nowhere between 3 like communities. So we couldn't move anywhere. We were literally the only commercial setting. So we couldn't move anywhere in either direction without alienating a substantial part of our practice. So we felt like kind of trapped in that location. So, I think it'd probably be different if I was in like a metro area.
Yeah. That is interesting about practice, layout and stuff. I remember when I found my building that I'm in, I found it and I was like, this is way too big for me. Like way too big. There's no way I'll ever use this much space. And I slowly started, I had 3 spare rooms, basically trying to rent them out. And over the years, I'm like, you got to get out. You got to get out. I need these rooms back. And now I'm like, I need a bigger space.
Yeah.
So it is funny how, but that goes into that, fear of when you're first starting out. And it's like, I remember just being like, I am hungry. I got to pay my bills. I'll take anybody. And it's really nice putting in that sweat equity and building it up to what it is, to where now it's like, man, I've worked so hard, and I still work very hard, but it's a different hard work, and I built my practice on screenings. I loved going to the farmers market. I have a different perspective on it's an opportunity to just chat and meet people in the community, right? And so I love doing that. And I know most people hate it, totally hate it, but I have a lot of fun with it. And so that's what's so interesting. We all have such different practices. We're all similarly trained, right? But we have such different practices and different ways to interpret and different ways to do it. And that's the beauty of what chiropractic can be for everybody.
Well, on that note, I don't think there's anything anybody can add to, cap it off. Listen, I personally had a lot of fun, with this conversation. I wish I could have been part of the panel the first time around, but I'm grateful to have the sloppy seconds of chiropractic. What I would love to, I don't know, listen, if you guys, are willing, anytime you want to get on a call and just chat, it doesn't even have to be structured questions, just chat about it and film it. I think it would be cool. And honestly, I think anybody who listens in is going to get some cool stuff out of this. So, if you do happen to watch and get through this, thanks. And maybe we'll do it again. On that note, I'm going to end the recording. So hold on.
Thanks for joining, everybody. This has been so fun.